Okay. So for this afternoon session, I'm gonna cover on disorder of lower GI tract. So that Azliana cover on the upper GI tract. If you want to talk about lower GI tract, there's so much to cover. So when Dr. Haris messaged me, I asked him what topics that you want to focus at least, because if not, it's not gonna finish in 1 hour. So these are the things that probably we can go more, I would say in depth, but the overview of these particular topics, right? So let's first look at acute appendicitis. It's so common, and we tend to like appendix sahaja. But okay, let's just read about this. So when we talk about acute appendicitis, again, it is most common abdominal surgical emergency. Usually in the second or third decades, but we now do see, in more aged people. The typical clinical presentation is periumbilical pain that migrates to the right lower quadrant, tenderness, nausea, vomiting, fever, and the rest. With the use of diagnostic imaging, so we can confirm and exclude the diagnosis of acute appendicitis. What about the pathogenesis of acute appendicitis? Again, this is more like a hypothetical pathogenesis, because it was hypothesized that appendicitis starts with an insult to the mucosa due to luminal obstruction. It can be due to many things like fecal leaf, or whether it is due to tumor, polyps, foreign body, or lymphoid hypoplasia. And because of this, it causes some injury to the mucosa, ulceration, which allows bacteria to go through the mucosa and spread through the wall. However, we receive so many appendix, we don't really see quite an significant obstruction to start with. So again, this is a circumstantial or hypothesized, and it is also said that pathogenesis of acute appendicitis, it can be one of the manifestation of the injuries, like hypersensitivity reaction, infection, and ischemic lesion. So the table there shows you the causes of acute appendicitis. So what we say microscopically, so it starts with, if it's an early appendicitis, it will first look dull with congested serosal blood vessels. And as it progresses, the appendix will become edematous and hyperemic, sometimes with fibrinous exudates on the serosa. And on cut section, we can see hyperemic mucosa with intraluminal pus. And if it is gangrenous, it will turn black discoloration, and the complication of appendicitis is perforation. So what we see histopathologically, it depends on the time, If it is early appendicitis, then you will see very minimal change. But as I mentioned here, in early lesion, we can only see neutrophils within the mucosa or within the epithelium. But as the neutrophils reaches the submucosa, it can spread quickly through the wall. So when it is acute suppurative appendicitis, what we can see is extensive mucosal ulceration with transmural neutrophil infiltration. So this is an image, where you can see this is intact mucosa, but you can see here there's discontinuation of the mucosa. So this is mucosal ulceration, and this ulceration is covered with necrotic debris and neutrophilic infiltrates. So again, higher magnification of the mucosal ulceration. So all this blue thing you see is neutrophils, and the pinkish here like this is the necrosis. And this is an image of muscularis propria, and this is the serosa. So we can see neutrophils in between the muscle layer. So this is transmural neutrophilic infiltration. So usually this is suppurative appendicitis. Alright. And the complication of acute appendicitis is perforation, peritonitis, and abscess formation. All right, diverticular disease. when we talk about diverticular disease, then we should focus on the terminology of diverticular disease. All right. So diverticulum is a singular name, and diverticula is for plural. So diverticula is outpouching of the colonic wall, and if when we talk about diverticula, it can be true diverticula or false diverticula. So true diverticula is when the outpouching composed of all layers of bowel. We know that bowel wall, they have 4 layers, yeah. So, and true diverticular is usually congenital. So false diverticular is the one that we usually see, the diverticular disease, yeah. It's only, the outpouching is, the layer is only mucosa and submucosa with very thin layer of muscularis mucosae. Diverticulosis is the condition where there's presence of single or multiple diverticula. Diverticulitis is when it is inflamed, yeah. Diverticular disease is usually asymptomatic, usually occurs more than 40 years old, equally common male and female. But there's been reports diverticular occurring in children, especially those with these congenital diseases such as Marfan and Ehlers-Danlos syndrome. This is said to be a Western disease, but now we see common also in our side of the this side of the world. Yeah, like more than 90% is a left-sided disease. Right-sided disease are more common in Asian. So what happens in diverticular disease? So how diverticular develops? So basically, if we study the bowel wall, yeah, they have weak points where the vasa recta traverse through the subserosa and penetrate the muscularis propria. Yeah, at the area between the mesentery and anti-mesenteric tinea. So because of this, these are the weakest points. So the mucosa can protrude or herniate through these points. Okay, so because vasa recta is traversed through the wall at regular intervals, so we also see the same. Diverticular is also follow this distribution. All right, so what is the pathogenesis of a diverticular disease? So there are numbers of etiology or causes for diverticular disease. One is structural alteration of the colonic wall. So it is said that diverticular is more common in person where they have some derangement in deposition of elastin and collagen. It also happens in those with abnormal bowel motility and when there's increase in intra-abdominal pressure. And the commonest cause is low fiber diet, yeah, because when there's low fiber, there will be low volume stool, therefore it will have a longer transit time and a more hard stool, yeah. So straining will increase the intra-abdominal pressure and thus leads to diverticular formation. So again, this is the pathogenesis, yeah. So because of low fiber diet, so it predisposed for diverticular formation. And the pathogenesis behind how diverticulitis happens is about the same as the appendicitis, yeah, where there is injury to the mucosa, leading to bacterial infiltration and inflammation. So what do we see? All right, so more than 90% it involves the sigmoid colon, yeah, and so if you can see in this image here, we can see multiple diverticula where the ostia or the opening is seen on the mucosa, and because of the inflammatory edema, there will be thickening of the bowel wall, and sometimes, yeah, they can have serosal fat wrapping and also adhesion. Okay. So what do we see microscopically in diverticular disease? So we can see the outpouching. If you look at this low magnification, yeah, so the mucosa outpouched through the muscle layer, yeah, into the serosa. So this is false diverticular because it is the layers is composed of mucosa and subserosa. Yeah. Again here, So the mucosa is normal, yeah, but sometimes they can show active and chronic inflammation. All right. So again here you can see here the outpouching. So the thin layer of muscle here is the muscularis mucosae. Yeah? So they lack of muscularis propria. This is a higher magnification showing you the normal epithelial. Yeah, sometimes they can have chronic inflammation also. And if there's ongoing inflammation, so or injury, they can have hemorrhage, a foreign body reaction. They can have lymphoid hypoplasia, fibrosis of the muscularis propria, hypertrophy of the arteries, and marked diverticulitis. So these are the complications of diverticular disease. They can ulcerate, they can perforate. The most common is hemorrhage, yeah, because as it out through the muscularis propria, the muscle wall, the blood vessels are there, so they can easily be hemorrhage. The ulceration, perforation, pericorneal abscess, fistula formation, yeah, if it's perforate and constricture and peritonitis. Okay, that's about that. Let's talk about inflammatory bowel disease. So inflammatory bowel disease is a chronic condition resulting from inappropriate mucosal immune activation. All right. So when we talk about IBD, we are talking about two diseases, yeah, Crohn's disease and also ulcerative colitis. So we used to separate Crohn's disease and ulcerative colitis, the pathogenesis, the clinical features. But now the distinction sometimes is a bit blurred. Yeah. So how we distinct UC from CT sometimes is based on affected site. Yeah. Because like in Crohn's disease, they are skip regions, yeah, where it involves the rectum and then normal and then another segment of inflammation. While in ulcerative colitis, it is continuous, yeah, from rectum up to continuous, and it ends somewhere with an abrupt incision between the disease and the normal colon. And ulcerative is usually limited to the mucosa and submucosa, while Crohn's is typically transmural. So we basically differentiate it based on this distribution and the morphologic expression of the disease. Yeah. So when we talk about IBD, we frequently see this in young adults, but there is a second incidence peak among the middle age, yeah, around 55 to 65 years. Again, both UC and CD are more common in female. IBD used to be very common. I mean, very common. It is common in the Caucasian, yeah, North American, Northern Europe, in Australia. But now we can see that the incidence worldwide is on the rise, yeah, and we can see it is more common now in this part of the region, yeah, Africa, South America, Asia, which historically it was quite low before. So when we talk about the pathogenesis of inflammatory bowel disease, the precise causes are yet to be defined. It is actually multifactorial. Yeah, there are um, many causes or etiology that contributes to IBD. Yeah, it can be due to genetic. Yes, genetically susceptible hosts is more predisposed to uh, aberrant immune response. Yeah. So there will be alteration in host interaction with intestinal microbiota, and because of some mutations or apa ni, polymorphism, there will be aberrant mucosal immune response, yeah, where like in this illustration you can see the epithelium is have some junctional defect which allows the bacteria to influx into the wall and trigger immune response, and this will further leads to more dysfunctional epithelium, and thus it is in a cycle. Yeah, and other causes is altered composition of the gut microbiome. If you look at the genetic component of this disease, they can prove that this is genetically associated, yeah, as the concordance rate in monozygotic twins with CD and UC, you can see that 15 and 15% respectively. And with the genome-wide association studies, they have identified more than 100 IBD-associated genes, yeah, especially not two as listed, yeah, where these genes involved in recognition of intracellular pathogens, yeah. So when there's polymorphism of these genes, it leads to inappropriate immune reaction to the bacteria, and thus leads to the pathogenesis of inflammatory bowel disease. Another, as mentioned, another factor which contribute to IBD is the deranged mucosal immune response. As we know that in the bowel, in IBD, there will be activation of T cells, yeah, and the T cells will be polarized into T helper 1 and T helper 17, and these T cells in response to that, they can produce cytokines, and this hyperproduction of cytokines and all, it contributes to the autoimmune disease. It contributes to the pathogenesis of inflammatory bowel disease, right? Okay, so again, this is just to illustrate to you the multifactorial component of IBD. Yeah, it can be due to genetic, yeah, in susceptible hosts, and also other environmental factors, yeah, where it affects the epithelial, it causes the epithelial to become dysfunction, and thus allow bacteria to translocate into the bowel, and leads to activation of immune response, and there will be derangement of mucosal immune response, and thus leads to this inflammation, which are the pathogenesis of IBD. Okay, so Crohn's disease and ulcerative colitis. So again, we can differentiate it based on the clinical presentation, the endoscopic findings, yeah, and also the microscopic findings, yeah. So if clinically we can see that Crohn's disease, they can have extra colonic manifestation also, and these are other things, yeah. They can affect the whole length of GI, yeah, as compared to ulcerative colitis, usually are more localized, yeah, starting from the rectum. Endoscopically, you can see skip lesions in Crohn's, but in ulcerative colitis, it is continuous. Stricture is more common in Crohn's disease. Microscopically, it's about the same, but there's some like granuloma is more common, more commonly seen in Crohn's as compared to ulcerative colitis and more. So just to show you the macroscopic finding of Crohn's disease. So in Crohn's, this is the colectomy specimen in patient with Crohn's. So we can see there's patchy distribution or skip lesions in areas like this. it is a diseased segment, and then a normal, like here is normal, yeah. So we can see skip lesions like that. And usually Crohn's, because it is transmural, it can cause stricture of the bowel wall. Yeah, so we can see this is normal, and the stricture, this is inflamed segment. And in Crohn's disease, there is cobblestone appearance, yeah, where we can see, so basically how cobblestone is formed, this appearance is formed is because the diseased mucosa is depressed, yeah, so leaving the normal mucosa to be appeared like a cobblestone like this. And because it is transmural, so in Crohn's we can see this linear mucosal ulcer, yeah. How about ulcerative colitis? So this is a total colectomy specimen. Yeah, so we can see that the lesion is continuous, yeah, from rectum up to the proximal colon. All right. So it appears reddish like this, yeah, granular mucosa because of inflamed mucosa. And at here, it looks more smooth compared to here. It is because of mucosal atrophy. This is some of the things that you can see in ulcerative colitis. As I mentioned, there is sharp demarcation or a transition here between the active ulcerative colitis and the normal bowel. They can have pseudopolyps, yeah. So they have this ulcers with, and this pseudopolyps is actually the regenerative mucosa. Okay, so it looks like island or pseudopolyps. And these pseudopolyps, sometimes the tips can fuse and forming this mucosal bridge. This is just to compare cobblestone pattern in Crohn's and pseudopolyps in ulcerative colitis. Yeah. So in Crohn's, we can see this linear mucosal ulcer, while in ulcerative colitis, it is more superficial. Okay, what are the microscopic changes in inflammatory bowel disease? So number one, we usually will look for chronic mucosal change. Yeah, so we say chronic mucosal change is we look at the architectural distortion. In normal colon, you will imagine like a test tube, yeah. So you can see nice crepes. But when architecturally distorted, you can see like here, yeah, it is branched, dilated, yeah, like this. So this is distortion, chronic, signifying a chronic changes. And usually the distribution of inflammatory cells, yeah, it is more dense in the superficial, towards the luminal surface. But in chronic mucosal change, we can see the plasma cells at this basally located, yeah. So we see more of basal plasmacytosis, which also give a clue for this disease. They can have metaplastic changes, yeah, signifying a chronic inflammation, so like pyloric gland metaplasia and Paneth cell metaplasia. So that is number one. So usually in IBD, we look for the chronicity, and then we look for the disease activity. So we look for cryptitis, where we see intraepithelial neutrophils. Yeah? So this is gland of crypts with neutrophils. This is crypt abscess, yeah, where you can see aggregate of neutrophil within the lumen, like this, until the crypt is distorted and ruptured. Yeah, so crypt abscess. If the IBD is more severe, you can see mucosal ulceration. And because it is a chronic inflammation, you can see lymphohypoplasia within the serosa like this. In Crohn's disease, we can see granuloma. Yeah, we usually describe as microgranuloma because the size is about the same size as the crypt. This is also to differentiate between granuloma in IBD and granuloma in TB. Yeah, in TB, the granuloma would be actually larger. Okay, so how do we diagnose inflammatory bowel disease? So it is very important to have a complete clinical history. And on top of that, a detailed endoscopic findings should be noted, yeah. And you should sample adequately, and importantly, it has to be representative. All right, and after the we have to also look at the histology. So it's not like the diagnosis is not depends on just histology. It has to have the combined um, between, you know, having a correlation between the clinical, endoscopic, as well as histologic findings. So just to show, share with you that there is a consensus, a European consensus on IBD. So there are a few statements in this consensus. So again, biopsy sample should be accompanied with clinical information, including endoscopic findings, duration of disease, type of treatment, and comorbidities. Because sometimes the form that we receive does not include all this information. So it is difficult for us to, you know, suddenly ask, is this IBD or not? It is difficult because yeah, sometimes we have to correlate with the clinical and endoscopy. So for a reliable, so another statement from this consensus is the reliable diagnosis should be on ileocolonoscopy, yeah, rather than just rectoscopy, and a minimum of 2 biopsies from at least 5 sites along the colon, including rectum and terminal ileum. Okay. And it is best that the biopsies collected you put in a different container and with a different label. So it will be more representative and will be better so that we can see, give a better interpretation. And then other statement here is it should be immediately fixed. And if you can see focal lesions, yeah, so it is recommended to this is histologic lah. If we see under the slides, there are lesions, we will usually do deeper. So that is what it means by deeper lah. We do a multiple sections, yeah, to examine more. And 2 to 3 levels, each with 5 sections. All right, so this is just to show you the summary of IBD. So you see, and also Crohn's disease. Yeah, as I mentioned, Crohn's can affect from mouth to anus. Yeah, so all right. So again, here another comparison of Crohn's versus ulcerative colitis. Okay, so that's about inflammatory bowel disease. So next will be on colonic polyps. So when we talk about colonic polyps, it used to classify it as neoplastic and non-neoplastic. But now, like hyperplastic polyps used to be non-neoplastic, but certain subset of hyperplastic polyps can have some malignant potential. So I think it is best for us to discuss chronic polyps based on the this classification. Yeah, we can say inflammatory polyps. When you say inflammatory polyps, it is non-neoplastic lah. And then hematematous polyps and epithelial polyps. Yeah. So inflammatory polyps, for example, like pseudopolyps, and prolapse type inflammatory polyps like mucosal prolapse syndrome. Yeah, they can have inflammatory polypoid deletion also. Hematematous polyps, we'll talk about the juvenile polyp and Creutzfeldt's syndrome. Juvenile polyp and juvenile polyposis I don't discuss on juvenile polyposis. I think you can read on your own about that. Yeah, and in epithelial polyps, we'll discuss on serrated polyps and also conventional adenoma. So okay. So inflammatory polyps, pseudopolyps is like in IBD. Sometimes non-IBD can also have some pseudopolyps. Yeah. In mucosal prolapse, polyp usually in SRUS, which you can read on that topic, inshallah. So hematematous polyp, what is hematoma? Hematoma is overgrowth of cells and tissue native to the anatomical location in which they occur. Okay, so Usually hematomas are solitary, but sometimes it can be part of polyposis syndrome, yeah, like JVA, juvenile polyposis syndrome, Creutzfeldt syndrome, and Gordon syndrome. So polyposis syndrome is less than 1% annual incidence of colorectal carcinoma. So if we talk about polyposis syndrome, yes, it carries a risk for malignancy, but if you're talking about sporadic juvenile polyp and Creutzfeldt polyp, they essentially have no malignant potential. So juvenile polyp, sporadic occurs in 2% of pediatric population, commonly in kids with mean age of 5 to 6 years. But sometimes you can see juvenile polyp in adults. So in these youngs, the presentation is painless rectal bleeding and collapse of polyps with the rectum. And usually it is in rectal sigmoid. And this is the gross morphology of juvenile polyp. Yeah, it is unilobated with smooth round contour. And cut section, you can see they, like a cystically dilated appearance, yeah, like a mucous retention cyst or retention polyp like this, yeah. So microscopically, what do we see? Cystically dilated, yeah, tortuous crypts. So usual crypts are like this, yeah, this probably the stalk, yeah, normal, small like this, but in juvenile polyp, it is cystically dilated, and there is inspissated mucin within the crepes. So sometimes it is called, because that's why it is also termed as mucus retention polyp before. Otherwise, the mucosa is normal, the epithelium is benign, yeah. The lamina propria can be edematous with some chronic inflammation, sometimes with acute inflammatory cells. And it can be ulcerated, associated with regenerative epithelium. This is just to show you sporadic juvenile polyp and juvenile polyposis syndrome. Yeah, I think you can read on this. So as mentioned, sporadic, the malignant risk of malignancy is essentially none. Yeah, but if you talk about polyposis syndrome, yeah, they have carries risk of malignancy. Okay, Creutzfeldt syndrome is an autosomal dominant syndrome characterized by mucosal pigmentation, yeah, like this. Distinctive hematomatous polyp, and also increased risk for malignancies. And usually we see these patients in the second and third decade of life. Creutzfeldt polyps, if you talk about sporadic, they can occur throughout GI, but most common is within the small bowel, followed by colon and stomach. And microscopically, what we see in Creutzfeldt polyps is this characteristic distinctive arborizing pattern of smooth muscle. So you can see like branch of trees, yeah. So arborizing pattern of smooth muscle, which derive from the muscularis mucosae. So when we see this, it is likely to be a Creutzfeldt polyp. And the epithelial lining is normal epithelial cells, yeah. So it looks a bit hyperplastic like this, but it is normal, yeah. So again here, just to show you that the arborizing pattern of smooth muscle. This pink is the smooth muscle cells. So I didn't discuss other polyposis syndrome, yeah, like Gordon's and CCS. I think you can read about this. Again, polyposis syndrome do carry some risk of malignancy. Okay, so we have talked about hematomatous polyp. Now let's talk about the epithelial polyps. So epithelial polyps, we can discuss on the serrated polyps and lesions, and also the conventional adenoma. So when we talk about serrated polyps, yeah, so serrated polyps, under serrated polyps, we have hyperplastic polyp, Yeah. So hypoplastic polyp, if it is just a normal hypoplastic polyp, it is a non-neoplastic where there is very, very low risk for malignancy. But sometimes hypoplastic polyps can grow larger and bigger, and it can have some mutation which will actually predispose it to dysplasia and later carcinoma. Yeah. So that's why I don't want to discuss this as a neoplastic, non-neoplastic, because serrated polyps can have this progression to carcinoma. All right. So basically, I just want to share with you that serrated polyps we can discuss, and then serrated polyps is hypoplastic polyps. Where hypoplastic polyps, they have some subsets, yeah, like microvesicular, goblet rich, and things like that. And then we have sessile serrated adenoma, and we have TSA, traditional serrated adenoma. So just to show you, okay, this is normal mucosa, like a test tube, yeah. But what happened in hypoplastic polyp is they will have proliferation of the epithelial cells, and that's why, because of this proliferation, you can see serration, yeah, like a zigzag like that. Like this is a straight one, but you can see zigzag like that. And in hypoplastic, it is usually downward like this, but in sessile serrated, it is boot shape, yeah, to the lateral side. Okay, and again, just to show you here that they can have some molecular alteration. Yeah, when we talk about serrated polyp, they can have BRAF mutation and CIMP um, mutation with methylation of amylase-1. That's why it leads to microsatellite instability. Yeah. So, and this is one part of sequence we will discuss later. So, hypoplastic polyps, the most common type of polyp in colon. Traditionally, yeah, non-dysplastic. However, now some may progress to malignancy. So this is the classification, yeah. Non-dysplastic, hypoplastic polyp lah, basically microvesicular, goblet cell hypoplastic, MCP. And we have the other serrated polyps. So this is how hypoplastic polyp under microscope, yeah. This is what we call the serration, the wavy sawtooth-like appearance, yeah, even here, yeah, on the surface. So and we can see that the goblet cells are there and benign looking. And in sessile serrated polyp, yeah, as we mentioned, in boot shape, yeah, we can see here they have lateral expansion like this. So when we see this, we say this is SSA, sessile serrated, SSP is sessile serrated polyp. When it is associated with dysplasia like this, yeah, we call as SSA. So this is normal. I mean, normal looking epithelial cells. This is with dysplasia. Traditional serrated adenoma is characteristically eosinophilic or pink with ectopic creep like this, yeah. So I think I've reported once in SUSMED. PSA. Okay, so that is serrated polyps. Conventional adenoma is also quite common, yeah, when we report as tubular adenoma. Oh, sorry, this should be tubular. So usually conventional adenoma, we will say it is tubular, tubulovillous, or villous. Yeah, like this is tubular, or like tubules, and this is tubulovillous, mixture of villiform architecture and tubular architecture, and this is villiform architecture. So we can divide this into low grade and high grade. So when we look at low grade, they can have pseudo stratification, but the nuclei is still basally located, yeah, cancellate or uh, ovoid in shape, hyperchromatic with mucin depletion. Yeah? But when they have high grade dysplasia, yeah, it looks like this. The nuclei are more rounded. There is loss of polarity, and the mitotic figures are numerous. Yeah. Okay. All right. Lastly, colorectal adenocarcinoma. So, in terms of colorectal adenocarcinoma, there's a lot of things to discuss. Yeah, I think the epidemiology, the risk factors for colorectal adenocarcinoma, I think you can go through it on your own. So I'm just going to talk about the pathogenesis of colorectal adenocarcinoma. So the colorectal adenocarcinoma, most, if not all, arise from adenoma. So and now we can see that there are distinct association, yeah, between the histologic type of precursor and the pathogenesis. So because of this, we can discuss the pathogenesis of colorectal adenocarcinoma into two pathways. Yeah, number one is the conventional adenoma carcinoma sequence or pathway, and the second one is the alternative serrated pathway or defective mismatch repair pathway. So the first one is the conventional adenoma carcinoma pathway, and this accounts for about 80% of all colorectal cancers. And when we talk about this conventional pathway, more prevalent in the left colon, yeah. Studies show that conventional adenoma progresses to carcinoma, the time precede to cancer is about 15 years, yeah. And now the endoscopic removal of adenomas have decreases this incidence in treated patients. So this is just to show you the pathogenesis or molecular changes in adenoma carcinoma sequence. So we can see that in this conventional sequence, yeah, we can see there's first hit, second hit, APC. Yeah, so some patients are born with germline mutation of APC genes. Yeah, so and sometimes they can acquire this mutation. So this is the first hit. And when there is inactivation of the second allele of APC, that is where the mucosa is at risk for a formation of adenoma. And so APC is learned to be happen in the early stage of this cancer development, yeah. And other mutation like KRAS, yeah, follows and other tumor suppressor genes and other additional mutations. Although we can see like there's a temporal sequence of these changes, yeah, but what's important is the aggregate effect of these mutations and not the order of occurrence, except for the APC which occurs earlier. All right. Okay. But now for the past 10 years, and this serrated pathway has been shed light on it, yeah. Have more focus on this, yeah, and it has been found that this serrated and defective mismatch repair pathway accounted for about 15 to 20% of all CRC, colorectal carcinoma. And of course, in this lesion, the precursor is the serrated polyps, yeah. It is more common in right colon, yeah, because SSA is usually found in right side. And as I discussed in the previous slides on serrated polyps, these polyps usually have BRAF mutation, sometimes with KRAS mutation, and also CPG island methylation phenotype, where when there's this mutation, it causes epigenetic hypermethylation of MLH1 gene promoter, and which this leads to the defective mismatch repair and microsatellite instability. So this is taken from WHO just to show you that the serrated pathway of colorectal cancer, yeah, normal colon, which have BRAF mutation, yeah, leads to the formation of hyperplastic polyp and serrated polyps, and when they have this methylation, which leads to MMR deficient colorectal cancer. Okay, same goes here, or CPG methylation. Okay, this is again another illustration, a simpler illustration to show you that um, the molecular changes in mismatch repair, where we can see where we talk about germline inheritance like in Lynch syndrome, yeah, and sometimes they can have acquired mutations of the mismatch repair genes. When we talk about mismatch repair genes, we have few genes, yeah, like MLH1, AMS2, MSH2, MSH6, and when there's a mutation of this, yeah, it leads to microsatellite instability, and with accumulation of mutations of other genes, it leads to carcinoma formation or development. All right. I think, yeah, that's about it. Any question?
Doctor, I have a question regarding the IBD just now.
Yes.
The bodies. On the pathology side, when we receive a sample of colon or ileum, do they actually need to fulfill the criteria to see the transmural ulceration, non-catalytic granuloma to diagnose the Crohn disease, or it can be only one criteria of it?
I see. So that thank you for the question. Again, that's why we need the clinical history and also the endoscopic findings. Yeah, because you see the patient, you do the scope, and you can see if you can see lesions, you should mention it in the report. So when that is one. Yeah. So skip lesions is usually seen in Crohn's disease. And again, when you want to diagnose IBD, you should take representative samples, adequate samples. Okay, we cannot just macam take rectum. Is this IBD or not? Take ileum. Is this IBD or not? No, we should take all the throughout the colon, at least 5 sites. So sometimes we can say Crohn's, sometimes based on also skip lesions. Yeah, contour. For example, like you send five A, B, C, D. So A is terminal ileum. So terminal ileum, there's some inflammation. And then B, you label as cecum. Cecum is inflammation. And then C is ascending colon is normal. And then transverse colon is normal. Descending is inflamed. Sigmoid is normal. Rectum is inflamed. So when we see this, it's like a patchy distribution, we can suggest that IBD favor Crohn's disease and things like that. And again, it has to be correlated with your clinical and endoscopic findings. So usually, but if you read our report, we usually the interpretation will be chronic colitis, see comment. So in the comment, we will actually interpret the whole as an overall histologic interpretation. So we will say overall histologic features show patchy distribution of inflammation and chronicity changes which favor IBD in view of patchy distribution. Crohn's is likely, something like that. And then we will ask you to correlate that. So I think we can, at certain extent, diagnose it on histology, but again, it is very important to have a clinical endoscopy findings. Am I answering your question?
Yes. Follow-up question. So
Mm.
if I do one patient, we do operation and then they come back chronic colitis, it is suggestive to us to do an endoscopy and taking a multiple site of specimen just to actually to make sure that we don't miss the IBD.
Uh, Again, usually I notice that like you will do multiple biopsies if clinically and endoscopically it is suggestive, right? Because if not, you will not do multiple biopsies like that. So usually I think it is back to you to because we again we very seldomly we diagnose chronic colitis just like that if you read our report, because it will not give any input to you. Okay, because unless we do see changes like Crohn's but you didn't mention, we will definitely call you and ask you. But usually if it is just based on one biopsy, we will not we will not diagnose. Sometimes if you read, we do say focal active colitis, and then comment kat bawah tu, we will usually say focal active colitis can be seen in non-specific colitis, in IBD. But again, you have to correlate like that. Not necessarily when we write IBD means you have to do the serial biopsies. Yeah.
Right. Thank you, Doctor.
Okay.
Dr. Karenisa, can I ask one question?
Yes.
The one regarding the colorectal adenocarcinoma, the pathogenesis that is two-type kan, the one that conventional adenoma pathway as well as the defective mismatch repair pathway. Is if let's say for example conventional adenoma pathway is actually specific towards specific to villus adenoma, or is actually combined of both mechanism for both serrata and also the villus adenoma to become a adenocarcinoma?
So it is
Yes.
I'm not sure if I understand your question, but to start with, adenoma is already a different pathway. So if you look at the slide just now, yeah. So for adenoma to occur is EPC mutation, but if serrated it will be a BRAF mutation or KRAS mutation. So to start with, the normal mucosa is a different pathway already. So if we say it's a adenoma, conventional adenoma carcinoma, that is adenoma. It's not part of serrated. Yeah. So yeah, am I answering your question?
Yeah. Understand. Because actually I'm a bit confused. I thought it's actually CRC is, for generally it's two pathway, but it's together. It's not like specific towards one villus adenoma or specific towards serrata polyps. Yeah, so that's why, yeah. Okay, understand.
Yeah.
Thank you, Dr. Karenisa.